Our last section for this chapter is going to be all about schizophrenia. Now, we have mentioned schizophrenia quite a bit throughout the semester, simply because schizophrenia is one of the most well-studied and sort of well-understood of our different disorders. So there's been lots and lots of research done on it. So it's been a really great topic to be able to give examples and sort of explain through how some of those studies and our understandings have grown and changed over time. However, we haven't necessarily delved all the way into what schizophrenia is and our complete understanding of it, or at least the Cole's notes of our complete understanding, but that's the intent for today. So starting off, what is schizophrenia? And if we actually look at the breakdown of the word schizophrenia, it's actually a little bit of a misnomer because it translates directly to split mind, which actually would kind of make us think a little bit more of dissociative identity disorder than schizophrenia, where, if you remember, DID was that idea of split personalities. However, with schizophrenia, it's not that you have sort of multiple personalities, it's more that you have sort of a single person who has sort of a fractured sense of reality, or who has different aspects of their personality expressed in slightly different ways. So we take the title with a grain of salt. However, we go for our proper definition. Schizophrenia is going to involve severe disturbances to patterns of thinking, speech, perception, emotion, and behavior. So we'll look at things like within thoughts. Delusions are one of those components where you might have false beliefs. And these are usually things that are sort of over-the-top beliefs, oftentimes sustained even in the face of evidence that would tell us that this isn't the case. So you might have evidence that says this is paranoid or this is too far, but you're going to persist with those beliefs despite that. While there are many different types of delusions, two that are fairly common with schizophrenia are delusions of grandeur, where the individual might overestimate their importance. They might feel like they are special or that they are somebody who deserves power and respect or something like that. And that can maybe tie in with the second one being delusions of persecution, the idea that somebody is out to get them. Oftentimes this would be seen in, say, media, where an individual would be worried that, say, a government organization is out to get them, or something like that. And so they might feel maybe that they are so important that somebody is out to get them. But in these instances, you might be able to provide evidence that, well, you're just a regular person or there's nobody out to get you, but they would be persisting with these false beliefs even in the face of that evidence. When it comes to disturbances of speech, we'll sometimes find that individuals with schizophrenia might be able or might struggle with producing organized, ordered speech. They might start using strange words, or they might hop from topic to topic without ever finishing a complete sentence. So you can often find that their words seem to make sense to them, but for someone on the outside, they might have a lot of trouble following what's being said or what the meaning is behind that. With perception is one of our sort of big ideas that people tend to associate with schizophrenia, and that's hallucinations. And so with hallucinations, you are hearing or seeing or feeling something that isn't there. So these are false perceptions. And interestingly, when you start looking at brain scans of individuals experiencing hallucinations, in some instances, you'll actually find the same kind of activation within their sensory cortex. So if they're seeing something, there's activation in the visual cortex. If they're hearing something in the auditory cortex. So we can actually see activation in those areas that would match what we would expect for actually seeing or hearing or feeling those things. But in this instance, they're having that experience in the absence of that kind of external stimulation. So something potentially going on internally, though our understanding of it isn't necessarily perfect. When it comes to emotion, we'll actually talk about something called a blunted affect or an inappropriate affect, where we've said before the term affect is just another word that can be used in place of emotion. So this would just be that they're feeling sort of less emotion or no emotion in instances that they should. Or for inappropriate affect, it might be that, say, they find something very serious to be amusing, or they might get really sad at something that shouldn't be sad at all. So there's a bunch of different ways that you can have that mismatch between what should be happening emotionally versus what is actually happening emotionally. And then we'll eventually get into behavior, and there's a bunch of different ways that behavior can be disturbed. So things like too much action or being unable to sit still. Or we'll even see instances where individuals might not be able to move as much as they should. So they might look like they've become frozen or have gone catatonic. So there's a whole bunch of variations there as well. But those are some examples of those different types of disturbances that we'd expect with schizophrenia: speech, thinking, perception, emotion, and behavior. And we'll see how all of those can be affected as time goes on in the chapter. Now, I usually do try and acknowledge that with our recent-ish update to the DSM-5, they did change a bunch of the ways that we categorize schizophrenia. So it used to be that they broke it down into these outdated subtypes. So this was from the DSM-4 and possibly even earlier, where they talked about paranoid schizophrenia, which is a term you probably still see fairly often in the media, where for those individuals, they experience lots of paranoia. That's where that delusions of persecution or grandeur would come in. We might also see disorganized schizophrenia, where they often show confusion or difficulty in connecting to their real life or their real world around them. They might be incoherent in terms of disordered speech. Sometimes you'll see catatonic schizophrenia, and those are when we see very severe motor disturbances, oftentimes individuals being unable to move or moving in a very atypical way. And then, of course, they have their sort of error term at the end, which is undifferentiated schizophrenia, where they'd have symptoms that don't really easily classify into any of the other subtypes. So this could be individuals with multiple symptoms that overlap a bunch of areas, or maybe lacking some of the key diagnostic features of one of those categories, but still having enough to be classified as having schizophrenia. But like I said, these are sort of outdated subtypes because a lot of more recent research and our recent understanding has actually allowed us to start changing up how we think of schizophrenia and how we frame it. So nowadays, we typically look at type 1 versus type 2 subtypes of schizophrenia. And the reason why they've done this is because we often find that there are two clusters of symptom types, one being positive symptoms and the other cluster being negative symptoms. And even though we might see that you could have multiple different positive symptoms, you often find that people with positive symptoms have other positive symptoms and negatives have other negatives, but it isn't as common for you to have both positives and negatives. And the way that I typically frame it is that our positive symptoms are things that are in excess of normal. So they are things that are more than what we would anticipate in normal functioning. So these are sort of our pathological extremes. So things like our delusions and hallucinations, so thoughts that are saying sort of above and beyond what you should be anticipating, hallucinating, seeing things beyond what are actually there. There are a bunch of different thought disorders and movement disorders and speech disorders that would all fall under here. Oftentimes things like talking too much or feeling too much or thinking in a scattered way. And so these are all sort of things that are present, things that are added, hence positive symptoms. Whereas for type 2, when we get into our negative symptoms, these are when we are lacking a typical reaction. So the absence of something in that situation. So this could be a lack of emotion or a lack of expression or a lack of motivation. And oftentimes, if we go into sort of the specifics of all of those negative symptoms, where something is lacking, they all start with A. So avolition or apathy would be that somebody has no initiative to accomplish some kind of task. They are apathetic to that situation. You might find allogia, which is the inability to speak, or anhedonia, which is this inability to feel pleasure from things that would usually be fairly enjoyable. An affective flattening, meaning that you have less emotional expression than normal. So you might not have your full range of emotional expressions available to you. Asociality, meaning that you're not really motivated to engage with others in social situations. And so with all of these types of symptoms, we see that there are very, very different patterns, with type 1 being sort of too much with those positive symptoms, and type 2 being not enough with some of those negative symptoms. But what does this tell us overall? So if we look onto this next chart here, just for a quick summary while I keep talking, we can actually start seeing that while most of what people think about sort of our stereotype view of schizophrenia, a lot of those characteristics fall under the type 1 or positive symptoms of schizophrenia. And those are the ones that are typically framed as being potentially dangerous, especially in a lot of media representations. However, what we find is that type 1 schizophrenia is actually not necessarily as harmful as type 2 can be, where type 1 schizophrenia is actually fairly responsive to anti-dopaminergic drugs. So we do have our dopamine theory of schizophrenia, or a dopamine hypothesis, I believe, which I think comes up in a few slides. But basically, we have this understanding that some of our symptoms of schizophrenia might be related to abnormal levels of dopamine. And so when we use drugs to treat those abnormal levels, those with positive symptoms actually tend to respond fairly well to those drug treatments. So they can have treatments that make it a lot easier for them to go back and function in their everyday lives. And we start seeing that for symptom outcomes, the type 1 symptoms are potentially reversible, where a significant chunk of individuals with type 1 schizophrenia can recover. So they might have symptoms for a while and then recover after the fact. We might even see that for some individuals, they might have a single event that would qualify them for a diagnosis of schizophrenia, but they would return to fully normal functioning after the fact, so showing almost a complete recovery, even just after a single exposure. So there is that potential for those to be reversible. In terms of intellectual impairment, we'll actually see that this is important later on, because long-term exposure or long-term having schizophrenia is often associated with deterioration in a bunch of different brain areas. So seeing some cognitive impairment over time can be expected, but it tends not to be as strong with type 1 schizophrenia. And so all of this taken together means that, yeah, this type of schizophrenia, while a little bit more sort of visible and has the potential to look a lot more severe, is actually a lot more treatable and possibly a lot more well understood. So yeah, we think that it's because of this increase in our dopamine receptors, and therefore it's showing activation in an atypical fashion along those dopamine pathways. But when we look at our type 2 or negative schizophrenia symptoms, we have those lacks of things. They tend not to respond to those same drugs, mainly because there is a different pathway that they think is involved. So it's not as well understood in terms of our negative symptoms. So these tend to last longer. There tends to be less potential for the symptoms to be reversible. Sometimes it can show cognitive impairment and long-term cognitive impairment, and a lot of that is linked to loss of brain mass, especially in and around our temporal lobes, though again, we'll talk more about that later on. But all of this tells us that, yeah, type 1 schizophrenia is a lot more treatable and a lot less severe over time, but type 2 is something that's still not well understood. Now, like I've said, there have been many, many, many studies over the years looking into the different sort of factors involved in schizophrenia. I think I've mentioned before, there was the Roscommon family studies, I believe is what the official title of the study was, but that was done back in the 60s in Ireland, where they started looking at biological relatedness and tracking those who had been diagnosed with schizophrenia, or those who had maybe been hospitalized with symptoms that were consistent with schizophrenia, or who had been arrested due to disturbances that related to symptoms of schizophrenia across time, and then track those back through family trees. mainly because Ireland actually kept very, very good records in all of those areas, and a lot of people didn't sort of leave the country or come into the country, so it was fairly easy to track down all of these biological relatives. And so they started doing these family studies, basically pedigrees, and they found that schizophrenia is far more common to occur within a family than outside of a family. So if we look at a family where there is a single instance of schizophrenia within that family line, you are far more likely to see other individuals with the same diagnosis within that family line than you would be sort of outside of the family, to the point that in the general population, the likelihood of developing schizophrenia is only, well, it's less than 1%. Somewhere between 0.4 and 0.7% is the standard estimate of different studies. But we're saying that in the general population, that is very, very unlikely. Whereas within a family, that rate climbs to be significantly higher, to the point that if we look at this one study here where they were looking at so a couple of different graphs here. I think this one will probably be the most important to look at first, but basically we were looking at adoption studies. And so we have individuals who were adopted and whether they had schizophrenia or did not have schizophrenia. And if we then look at, okay, related to their biological relatives versus adoptive relatives, those with schizophrenia, their first degree biological relatives, meaning their parents in most cases, were far more likely to have schizophrenia than if we looked at our controls. But also, the other important part here is that those who had schizophrenia but were adopted, their adoptive parents did not have schizophrenia. None of the people in this study showed that risk, meaning that we would say it's fairly likely this is related to shared genes and very unlikely to be related to the environment in which they were raised. Because if there was a large effect of the environment, then we would be seeing that these parents of these adopted children with schizophrenia diagnoses later in life, the parents would likely also have schizophrenia. Of course, we can have our sort of critical thinking in the background of adoptive parents would probably be screened for disorders like schizophrenia and things like that. But when this sort of pattern lines up with other things like over here, our cumulative risk of schizophrenia in relatives of those who either have schizophrenia or do not. So this squares line is for those who are related to someone with schizophrenia. Their cumulative risk as they get older ends up being much, much higher than those who are in our control group. So this is showing that in that general population, less than 1%, but within families with schizophrenia, you're getting up to sort of 6 or 7% versus that 0.4 up to 0.7 that we'd see in the general population. So this tells us that there's a pretty large effect of genetics, to the point that when what are we having here? Lenzweger and Gottsman back in 1994, not that the names matter, but they actually found that the concordance rate for schizophrenia is 3 times as high in identical twins as in fraternal twins, meaning that when you share all of your genetics, it makes you far more likely to share that diagnosis. And if we do a sort of general overall calculation, the heritability for schizophrenia tends to be around 0.80 overall, which is absolutely massive. So this tells us that we are fairly certain that there is a very strong component of our genetics involved in schizophrenia. And now we do know that we do have to separate out those environmental effects, hence looking at adoptive studies as well as twin studies. And sometimes you can get both. But this does give us some pretty good confidence that it isn't just the environment. Oh, too far. And so just another way to present some similar information with a little bit of a more modern study, where we'd say, okay, so if you are related to, you have an identical twin, and they have been diagnosed with schizophrenia, what is your likelihood of also having schizophrenia? Almost 50%. If we have a child who's been born to 2 parents who have schizophrenia, still almost about 50%, which kind of makes sense. You're getting about 50% of your genes from your parents, but that could also include some environmental forces. That's fine. With fraternal twins, this is where we see that distinction where identical twins are far more likely to be the same. While if you have a fraternal twin with schizophrenia, you're almost 20% likely to have that disorder yourself. If you have one parent who has schizophrenia, about the same. If any of your other siblings have schizophrenia, you are about 10% likely to have it yourself, and so on and so forth. We'll see it as it sort of fades outward, that the less related you are to someone, the less likely it is to share that diagnosis. But this does follow sort of that predictable pattern that we would see if there was this genetic component. Now, it isn't perfect, of course. There are always going to be other forces, risk, or in play here, but this is just sort of one way to interpret that information. And then one more graph showing something fairly similar, just to stress how sure we are about this. This study was looking at the children of twins, so either identical twins at the bottom or our fraternal twins at the top. And this is basically saying, okay, so if we have these identical or fraternal twins, and we know that they do or do not have a schizophrenia diagnosis themselves, what is the likelihood that those twins' offspring, their children, would be to have schizophrenia? And that seems like a really convoluted test to do. Like, why would we calculate this? But the findings definitely make this worthwhile. Because if we look at one of the fraternal twins who has schizophrenia and one who does not have schizophrenia, you see that the twin who developed schizophrenia, who got that diagnosis, their children are fairly likely to also have schizophrenia themselves. So in that sort of 17% range that we saw on the previous slide here. Whereas if we have the fraternal twin who did not receive a schizophrenia diagnosis, that risk in their children drops off dramatically. So this is sort of saying that in order for the twin with schizophrenia to have gotten it, they must have inherited some genes that predispose them towards it. And they could pass those risks, those genes, on to their offspring. Whereas a twin who didn't receive the diagnosis, our fraternal twin, they must have gotten a different 50% from one of their parents and not inherited the risk, and therefore couldn't pass it on to their offspring. And the reason why we think this way is because if we look at the same kind of information with identical twins, keeping in mind that they have identical DNA, our twin with schizophrenia would have inherited those genes that predispose them to schizophrenia, and they pass them on to their children, hence the bar. But an identical twin who didn't develop the disorder still has the genes that put them at risk. And therefore, they could still pass on those risk factors within their genetics to their offspring. So now, because they have those genes at risk, it's all about the environmental influences that would determine whether they and or their children would develop the diagnosis themselves. So this kind of a pattern gives us a lot more confidence from a slightly different angle that, yeah, there is definitely this biological or genetic factor that's playing behind the scenes. Now, for some of our mechanisms that might be going on here, I did state that we have some theories, but they don't always hold consistently. And the biggest one for schizophrenia is our dopamine hypothesis. And this is a theory that schizophrenia is related to high dopamine activity. And before we had said that we have sort of this overproduction of dopamine receptors, which would mean that even if our levels of dopamine are sort of regularly expressed, having more receptors means that our neurons are going to be more reactive. They're going to be more responsive. So they are going to provide a lot more activation in those areas that are normally sensitive to dopamine. And so that increased sensitivity, high activity in dopamine levels, or high activity caused by the dopamine that's present is probably the better way to say that. It ties into this sort of secondary aspect, the aberrant salience hypothesis, that basically says that heightened levels of dopamine activity would increase our intentional and motivational circuits to make ordinary environmental features seem significant. So if we remember back to how information enters our brains, where all of our sensory information comes up through our spinal cord, and it usually gets filtered through our thalamus. I say usually because our sense of smell gets excluded, but all of our other senses are going to filter through the thalamus, and then they get sent off to other parts of the brain. But as part of that filtering process, entering up into the brainstem and towards that towards that thalamus, we actually find that there are a lot of places that can sort of assign significance or importance to those incoming stimuli, where this would be saying that some normal stimuli, things that would normally be, say, ignored or filtered out or of no importance, are now being flagged as important, as necessary. And so that would mean that things that would usually not draw our attention are now striking us as important, things that we should be paying attention to, that we should be interacting with. And this could be why we're seeing things that aren't necessarily there, or feeling things that aren't necessarily being stimulated the way that we're feeling them, and so on and so forth. So clearly, this is still fairly vague in terms of our understanding, and a lot of this theory comes from the fact that before we understood how schizophrenia worked, at least sometimes, they found that using dopaminergic drugs was effective in reducing some of the symptoms of schizophrenia. But as we've seen from before, this is mainly going to affect positive symptoms. And we found that most negative symptoms are non-responsive to this kind of treatment. And this is one of the reasons why people were so uncertain about this hypothesis until we started treating positive and negative symptoms as sort of separate subtypes of schizophrenia instead of lumping them all together like they used to in older versions of our diagnostic manuals. Now, like I said, they did stumble across that dopamine effect sort of by accident. They were actually treating something else, and that happened to affect dopamine levels, dropping the activity of dopamine, and it happened to reduce symptoms in those who were diagnosed with schizophrenia. And so they figured that that was the best way to start treating schizophrenia, and it was effective, so they kept it around. So this is one of those cases where the treatment actually came before the theory, and then the two kind of co-evolve. But with this process, we actually ran into some issues where some of our earliest types of treatments, our antipsychotics, ended up having some pretty severe side effects. And one of the biggest ones for schizophrenia is something called tardive dyskinesia. And this is when an individual who has been on these dopamine blocking drugs for so long that it's starting to actually affect the expression of those receptors. And so these individuals would start showing involuntary movements due to that long-term blockage of those receptors. And this is something that eventually starts causing fairly long-term effects, something that wouldn't be reversible. It wasn't until they started developing newer treatments, or sort of our second generation of antipsychotics, where they were starting to be able to adjust dopamine levels without the potential for this long-term and untreatable secondary disorder. But of course, they didn't figure that out until much, much later. Our other theory here, because it's not just dopamine, there is also a theory that glutamate might be involved. So another one of our neurotransmitters, where in this case they say, okay, the hypofunctionalities, underfunctionality of our NMDA receptors leads to an increase in glutamate, and that's how we see an increase in dopamine. So they would say that, hey, there could be a change anywhere along this pathway, whether it's in the number of those receptors or the activity of those receptors, or the levels of glutamate that come from that, or the levels of dopamine that come after the effects of glutamate. All of these could be involved. And the reason why this theory has been sort of entertained a lot more recently is because depending on the modulation of each of those different effects in this particular pathway, we could have them explain both positive and negative symptoms of schizophrenia. So it still includes the aspects of dopamine levels affecting positive symptoms, but that glutamate inclusion now means that we could start explaining negative symptoms as well. So this was sort of a big breakthrough at the time. Again, it's still not perfectly well understood. There are other factors that need to be considered. One is the fact that when we look at individuals who've had this schizophrenia diagnosis for a long period, we find that there are sort of changes in activity in pretty much every part of the brain. Their patterns of activation overall start changing dramatically. And we actually start seeing physical deficits where we've had loss of brain tissue in different areas, once again, depending on the length and severity of symptoms. And just like we said before, those with negative symptoms seem to have far more degeneration within their brain tissue than those with positive symptoms. So if we look at this image here, we have identical twins. So they got brain scans of identical twins, and they found that the one that has a schizophrenia diagnosis here on the left, then we would see that they have larger ventricles. So I guess, first off, what are ventricles? You might remember they are sort of those spaces within our brain. We have, I believe, 4 different ventricles that are all labeled their own way. And they're basically large fluid cavities where that's how things can move from one part of the brain to the other fairly quickly. So when we look at different kinds of brain imaging techniques, a lot of them are going to monitor movement through some of those ventricles. But with individuals with schizophrenia diagnoses, we find that their ventricles tend to be enlarged. So we can see on the side here, instead of just looking at a single set of images from these identical twins, so the assumption being that their brains should be the same from same genetic backgrounds, though the one with schizophrenia has much larger ventricles than the one without. And that holds with a larger subset of measurements here, where they've included sort of their midlines, where on average, those with a schizophrenia diagnosis have much larger ventricles. This is just our ventricle to brain ratio. So higher means larger area devoted to ventricles. And the fact that they've taken a ratio is just to help us account for the fact that individuals can have different brain volumes, and they've just controlled for that. But what this would also tell us is that if our ventricles, if these spaces are getting larger, then that means that to account for that, we would have had to have lost brain tissue around those areas. And in fact, we see large amounts of tissue loss in and around our temporal lobes off to the sides of our heads in and around here. So that would include a lot of these subcortical structures. So in here is where we'd have a lot of the stuff we talk about in terms of our limbic system. So things like memory and movement and a whole bunch of other things. So this shows us that, yeah, there is this loss of brain volume. For another visual representation here, this one is showing on the top activation of the left and right hemispheres of an individual without a schizophrenia diagnosis, whereas on the bottom, left and right hemisphere of an individual with a schizophrenia diagnosis. Now, it is kind of frustrating because most of these are from older studies, some of them much, much older. So we don't actually get that division between positive and negative symptoms like we would have nowadays. But as I always say, our texts are usually a little outdated. But at least this does show us that there is this reduction in activity in the individual with schizophrenia. And we especially start seeing differences in this dorsolateral prefrontal cortex. Now, the dorsolateral part isn't super important. That's just telling us the location, basically. But towards our prefrontal cortex, we have talked about this area over and over again because that's the part of our brain that's responsible for a lot of decision making and choices on whether to act on certain sort of impulses or not. So a reduction in activity in that area might explain, say, atypical expressions of emotion or atypical behaviors because of the changes in activation in this really, really important part of the brain. So one possible thing to consider. And of course, there are many, many areas of the brain that have also been implicated, but this is at least an important one to talk about. Now, this next little bit here is actually a very strange study that found a link between rates of schizophrenia and our uh, severity of flus going around at the same time, which seems like a really weird thing to look at. But what they did was they tracked the severity of influenza cases within the country, so high to low. Oh my goodness, what my brain just stopped on that. High to low cases. And what we find is that for those cases where we have high rates of influenza, we end up consistently finding more individuals being born who will later be diagnosed with schizophrenia. And if we look at when these peaks happen, so this would have to be at birth. So if we were looking at some of those prenatal influences of the environment, the mother having a severe case of the flu during that period might have affected some of the development of their unborn child. So children born sort of between March and June, July would have been a few months pregnant during the peak of flu season, which is usually in winter. And we can even sort of boil that down where we'd say, okay, how many months after the start of that flu epidemic, whenever we'd have that sort of breaking out of flu symptoms, we'd find that 4 to 5 months after the flu started, children would be more likely to be born with schizophrenia diagnoses in their future. So this might be a link. There are, of course, many other factors that could have been involved here, but this found sort of one of those patterns to start considering not just some of our biological components or genetic components, but also the fact that there could be some environmental factors involved as well. So things like high stress that might not be stress after birth, especially into adulthood, but this could be stress in that prenatal environment that could predispose you towards schizophrenia in the future. So one more possibility. So what other types of environmental factors? We just said stressful life events can interact with other vulnerabilities. Back to that diathesis stress model, where you might have a predisposition, but there would be some environmental influence that could play a role as well. We find high reactivity, so something maybe personality related, where you tend to be much more reactive. That tends to correlate with psychotic behaviors. We also find that family dynamics can increase the likelihood of having a schizophrenia diagnosis in the future. Now, one of the areas that they study a lot in terms of sort of family dynamics is something called expressed emotion. And this is a really interesting concept because expressed emotion can come from usually from parents, but can be from others in the household, where the individual with schizophrenia or who would have that diagnosis in the future oftentimes experiences high levels of criticism, maybe high levels of hostility or resentment, and the family members might become over involved in this person's life. Now, we always keep in mind that homes high in expressed emotion might influence a diagnosis of schizophrenia, but having a family member with schizophrenia who has to rely on their family to, say, support them or to keep them on their medications might end up developing sort of this relationship where those individuals might become more hostile because they don't want to have to be responsible for someone else beyond what they anticipated. So parents who have a child with schizophrenia might have assumed that their child would be off on their own and independent, but they're stuck relying on their parents because they're unable to function in society. So that could breed hostility and criticism and things like that. So this is another one of those where we have a correlation, but our directionality could go in either direction, and it could be both at the same time. Another really interesting factor that'll tie us into our next page on sociocultural factors is that expressed emotion and its effects can differ dramatically between cultures. So because our standard in a sort of North American discussion of psychology is that we use North America as our baseline or comparison, for North American homes, expressed emotion tends to be fairly negative. where that level of criticism or hostility is interpreted as sort of a personal attack and is therefore highly stressful. But if we look at other cultures where, say, it's very common to live with other members of your family, where it's common to lean on others within your family group for support, especially in a lot of Latin American countries, expressed emotion isn't necessarily as intensive. And it might not have the same kind of level of effect because individuals aren't necessarily resentful of caring for others in their family. That's something they expected. We also find that recently they've looked into Black families where expressed emotion actually overlaps quite a lot with how affection and care is often shown. So being overly critical or sort of being a little bit snarky could just be interpreted as people caring for you. And families tend to get involved in sort of their other family members' business, which isn't necessarily seen as outside the norm. And in some of those studies, they've actually found that expressed emotion ends up having a protective effect within those groups. So it's more about the cultural aspects and what these types of behaviors are interpreted as, rather than treating them as sort of a factor on their own in isolation of that sort of cultural aspect. And like I said, in relation to that, we can touch on other sociocultural factors where there are a lot of other things that are related to schizophrenia and the society that it's occurring in. So if we look at the first being our social causation hypothesis, and we're actually going to be looking at these two hypotheses as sort of different ways that we can frame the fact that we see a strong correlation between socioeconomic status and likelihood of schizophrenia diagnosis. And this is something that's fairly often seen because if we look at, say, populations of homeless individuals, they are far more likely than the, say, 0.4 to 0.7% of the remainder of the population to have schizophrenia. Their rates are up to 10 times higher. So is it that being in that stressful environment of living on the streets predisposes them to schizophrenia? Or did developing schizophrenia cause a sort of loss of their ability to support themselves, which would lead to homelessness? And that's where these two different theories come from. So the social causation hypothesis says that those who are in low-income populations, in that low socioeconomic bracket, they are experiencing higher levels of stress. When you're worried about keeping a job and maybe not having enough money to pay for rent, those are high stress environments, and it could be a more you would be more likely to encounter those severe stressors that could predispose you to have schizophrenia or to develop it in the future, especially if you already have an underlying diathesis. Then the second, the social drift hypothesis, says that as functioning deteriorates, as the disorder sort of persists, individuals might drift down the socioeconomic ladder simply because they can no longer continue working to support themselves. And if they don't have family to rely on, then they would be left sort of with shelters or living on the street, depending on what's available to them. And it might also be a little bit of both, where you could be predisposed towards the disorder because of stress, and then losing your functioning can actually cause more stress as you lose your ability to support yourself. So this could be sort of a back and forth spiral where it makes it harder and harder to sort of get out of living on the street and to get proper treatment to be able to go back to living and functioning within society. So it's kind of interesting to see. And the last point here is just that we see very minimal differences between cultures when it comes to rates of schizophrenia. So even though we might see some variation in the relative contributions of certain aspects of, say, different things like our expressed emotion or other aspects like that, overall, we see very similar rates of schizophrenia across pretty much all of the countries that they've studied. Some are a little bit higher or a little bit lower, but effectively all within the same range. So this tells us that that large genetic influence that we started off with is something that isn't exclusive to any specific part of the world. So it's kind of interesting to see that because not all disorders are that equally represented around the world. So an interesting place to end.